Welcome to the first session of the SCT training program. The first couple topics that we'll discuss are the legal aspects, medical legal aspects of the specialty care transport program. We'll talk a little bit about what the SCT Paramedic does in Connecticut, and we'll also go over what local protocols we have to follow here in the Bridgeport and Stamford area. So when we look at the history of interfacility transportation, there's normal or typical transportation, which is usually by ambulance, and then there's critical care transport, typically by helicopter or by airplane. The SCT program falls somewhere in the middle, where transport is conducted by a paramedic, either by ground or by air, but that paramedic has received additional training. And specifically, the phrase SCT, or specialty care transport, comes from a Medicare requirement that a patient who's transported by ambulance but requires more medical care that a paramedic is generally trained to give, it becomes a different category with specialty care. Typically, paramedics who have SCT or critical care training have been trained in how to perform surgical airways. They conduct invasive monitoring, like line monitoring. There's usually ventilation of an intubated patient involved. There may be blood or other IV drugs administered through infusions and pumps, typically drugs that are not carried by a paramedic. Paramedics with specialty care training are often trained in using RSI, or rapid sequence induction, for intubation. They may access central venous lines and monitor arterial blood pressure through A lines. Protocols are written to give us a scope of what we are allowed to do, when we do them, and they must be written in advance. So they're established by our medical director. In Connecticut, the SCT programs are currently local programs. They're established by each hospital and each sponsoring agency. However, since the state has just come out with a recent update creating a statewide EMT and paramedic protocol, we will soon see a statewide SCT program also. Our program is set up such that we follow basic protocols, but each time we take a patient who's receiving a medication or a therapy that's outside of the normal paramedic scope of practice, we receive specific written orders relating to those medications or therapies. And this brings the patient care up to the SCT level. What's useful about having written protocols is that it puts out in advance what's expected of the provider, both of the physician who's sending the patient, the physician who's receiving the patient, and the paramedic who's caring for the patient in between. It provides us a legal framework and gives protection to all the parties involved. The National Highway Transportation Safety Administration groups a slightly different way than we do with BLS and ALS.
Basic transfers are considered to be routine. So it doesn't mean BLS or ALS, but it's the level of training that the provider has. Advanced means that it's a patient who is receiving therapies beyond what a normal EMT or a normal paramedic would do. We can also meet this standard by bringing certified or licensed personnel such as respiratory therapists, nurses, perfusionists, and physicians along. However, in many cases, they're not necessary, and it works just as well to have a well-trained paramedic on board. We look at the different levels of acuity with a patient, the lowest being unstable, the best being a very stable patient. Generally, the categorizations are that a patient who is stable with no risk for deterioration can be transported with basic transport by a BLS crew. Patients who have stable vital signs with low or medium risk for deterioration are frequently transported at the ALS level. So they'll have cardiac monitoring and possibly IV access and medication running. Patients who have a high risk of deterioration or who are currently unstable are generally transported with life-sustaining measures, such as ventilatory support, constant IV medication, and monitoring. And that has to be by licensed personnel, or in our case, specialty care trained paramedics. So the Centers for Medicare and Medicaid defines specialty care transport training as being beyond the routine training that a paramedic receives. So we'll talk a little bit about how we're going to conduct a call. We need to assess our patient and the situation each and every time we conduct a critical care or specialty care transport. We'll find out from the staff what the reason for the transport is, whether they're going to a center with higher acuity or a specialty resource center. We should perform a full assessment of the patient. This usually is not set up like a routine call where we go up, scoop a patient up, and take them to the destination. This should involve extra time, proper assessment, and planning for care. We also have to make sure that our program meets our medical control requirements. For example, we don't want to go to a hospital and transport a patient on a medication that is not approved by our medical director. We do have to have a set of written orders specific to the patient for any medication that we do not carry or routinely administer. So for example, if a patient is on IV antibiotics, we need a specific written order for that antibiotic. Perhaps they're on a vasopressor that we're not familiar with. We need to have a written order with not only a dose, but also an increment to adjust it and a goal. For example, we may be told to administer Levophed at a certain dosage and titrate that by micrograms up to a specific blood pressure. We should also have a backup plan ready for diversion or for vehicle breakdown or communication failure so that we can still serve the patient properly. Keep in mind the different methods of communication that are available. Most likely the best way is by cell phone, although a good backup is the med radio. Often our patients are coming off of a critical care unit and not the emergency room, where they're often used to talking on the radio. Come up with a plan about when and why you would consider contacting medical direction. For example, if the patient became unstable, if they had an airway compromise, or you needed to make specific changes to their medical therapy. Our documentation for specialty care runs is a little bit different because it follows more of a nursing model, as also our assessment will. We will have separate paperwork for each SCT run, and that allows for full quality assurance and follow-up and documentation of any care that's outside the scope of a routine paramedic. We should also document incident reports when things go wrong, when there's equipment failure, or the patient does not respond in the predicted way to a certain drug or therapy. For example, if a person refuses to be transported, or if they go into cardiac arrest during transport, or if we are partway to our destination and are diverted for some reason to another facility. We should certainly document any of these things separate from the medical care record. Talk a little bit about the legal aspects of specialty care. We're going to talk about EMTALA and go through preparing and accepting a patient for transfer. We'll talk a bit more about documentation and look at liability and how to reduce our liability when caring for patients in the SCT realm. When we look at the liability that's out there, skills that we perform on a regular basis with minimal risk are usually low liability. For example, lifting and moving patients we do on a daily basis. We establish intravenous lines on a regular basis. However, high risk and low frequency skills such as RSI, surgical airway, cardioversion, needle decompression, these are skills that we don't use every day, and they carry a high liability. Those are the skills that we need to practice and document practicing on a regular basis so that we can protect ourselves in the case that something does go wrong. EMTALA, or the Emergency Medical Treatment and Active Labor Act, generally applies to hospitals that have emergency departments, and it only applies to those that receive federal money, which is all of them in our area. A completely private hospital that does not receive Medicare or Medicaid funds is not subject to this. It requires that any patient that shows up on the property of that hospital claiming to have an emergency receives a screening exam, so a proper physician exam, stabilization, and treatment before there's any transfer to another facility. So this is any time that a patient is received onto the hospital property, including the grounds, or treated by hospital personnel. When working for a private ambulance company separate from a hospital, EMTALA does not apply until you've arrived on the property of a hospital. However, in some cases where hospital personnel are the field paramedics or they operate the ambulance service, it might be considered an EMTALA violation for a person to be treated by a hospital paramedic and then not taken to that hospital. Our scope of practice sets forth what we are allowed to do. It's established through a set of rules and regulations, protocols, and it gives us a framework for what we are allowed to do, subject to our medical direction. We do need to protect ourselves, and some people will carry personal malpractice insurance, whereas most employers carry some sort of liability and malpractice insurance should the wrong care be provided to the patient. Our scope of practice establishes what activities and procedures our paramedics are allowed to perform, and just equally what they're not allowed to perform. For example, a paramedic is allowed to conduct childbirth. However, conducting a C-section would not be within the scope of practice of a paramedic, even in a rare case. When we look at the scope of practice, there's other terms that come up. For example, you may have received education in paramedic school or another location in how to conduct RSI, rapid sequence induction, or perhaps surgical airways. The fact that you are trained in it doesn't mean that you can do it, because you additionally need to receive certification, licensure, and local credentialing, what we call medical control. Certification is usually verification by an outside body, which is why we have the National Registry, the American Heart Association, ACLS and PALS programs, PHTLS. These all certify that you have demonstrated some level of competence and understanding of a specific topic. When you get your license, it's the state performing you to do certain activities that are otherwise restricted or prohibited. And then your local credentialing is what gives you the permission to act in the place of a physician. The Venn diagram kind of explains how these things are combined. There may be skills that you're trained to do, like RSI, but in a certain area, you're not credentialed to perform them. For example, a New Haven paramedic does not perform RSI, but they do have the ability to perform a surgical airway on a patient. So it's all requiring medical direction, a license to practice, certification, and training. Those skills that are high risk and low frequency require repeated education and repeated competency demonstration in order to retain those skills. Our patients have a right to self-determination. They are allowed to refuse all or part of our care, including during the actual care. For example, a patient can accept an IV and then refuse to have blood put through it. They can accept transportation to the hospital, but refuse immobilization. So for a proper transfer, the SCT medic has to prepare for the call, transport the patient safely, and then turn over care at the receiving facility. At the beginning of the call, we need to get the assorted paperwork, including transfer paperwork, copies of records, whatever procedures and tests were done. We should also get a verbal report from the sending nurse and physician. We also need to confirm that the patient has a patent airway, and if necessary, protect it. Most critical care paramedics are trained to perform RSI if necessary, so they can use the proper skills to protect the airway during transport. We should ensure that our patients have IV access, and if it's not sufficient, we should add an additional access. We hope the patient is hemodynamically stable, but in some cases, especially coming from smaller hospitals, the patient has not yet been stabilized, and that's why we're transferring them. We're looking to document baseline vital signs, mental status, circulatory function, airway. And we might need to consider immobilizing the patient either for broken bones or for the protection of themselves through restraints. We should be prepared when a patient is not safe for transport to politely and properly refuse to take the patient. When refusing, it should be done in a professional way, not by yelling or walking away, but instead making a plan of action so that the patient can still be treated and transported properly, perhaps by bringing additional staff or sending them by a more appropriate means of transportation, perhaps by helicopter. When a physician sends a patient from one hospital to another, they must have made contact with a physician on the other end, and they have to document that that patient has been received. During transport, there should be a plan of action for the patient, and there should be a plan in place that if the patient deteriorates, the paramedic can provide management for the patient. The EMTALA law requires that certain paperwork go with the patient when transferring from one hospital to another. So there has to be the medical record about the current condition, including the signs and symptoms, the diagnoses, any lab results and x-rays that were done. And there's always a transfer form that involves clearly identifying the risks and benefits of transportation to the patient. That's usually signed, and it includes things like the possibility of having a car accident while being transported in the ambulance. We'll need to collect basic patient demographic information, and we should conduct our own assessment of the patient in cooperation with the nursing staff. A full, proper assessment should be conducted, not just as if we were finding a trauma patient, but more as if we were attempting to join in the diagnostic process. So not just a quick ABC look, but really looking into all the body symptoms. We should be aware of how to get a hold of medical control. We usually utilize offline medical control, our protocols and written orders. However, we should have a plan for how to get a hold of a physician at both ends if necessary. During transport, we want to continue monitoring the patient. We want to provide sustaining life support as necessary. If it's a long transport, we should keep in mind both hydration and feeding and need for elimination, whether it be bathroom visits or Foley catheter. We need to also document, and we usually have adequate time to document carefully. At the completion of transport, we'll give a full report, usually to the receiving physician, sometimes to a nurse or an advanced practitioner. We should ensure that they receive all the reports and paperwork from the sending hospital, and if possible, a copy of our report, which might be generated later. The COBRA Act and EMTALA also explains when a patient can be refused treatment entirely, or if they have to be transferred to another facility while still unstable. Here we see a situation where a patient comes to the emergency department requesting examination or treatment for a condition, so that they have to get a proper screening examination. They have to either be given care or transferred to a hospital that can provide care. The patient can request transfer, and they should be informed about the risks and benefits about transfer. But we have to meet these three criteria right away. The patient has to be treated and stabilized as far as possible. We have to find out that they need medical care at another location. And the physician should see which of those two holds the most merit, whether it's transporting the patient or treating them there. When the decision is made to transport, the transfer should be done with qualified personnel and equipment, which means that if the patient needs to be on a balloon pump, they should go with a balloon pump and not wait to have it at the other end. So here's a scenario. This is a true case, and there's money involved with it at the other end. So it involves an ambulance service. So at midnight, a pregnant woman goes to the medical center, the Burt Fish Medical Center, with labor pains. The physician examines her and decides that she is in the early stages of labor, but says that they don't have a birth center ready to handle a premature infant. So Dr. Milton arranges for transfer to Halifax Medical Center. The obstetrician there consults with Dr. Milton and sees that they have a neonatal intensive care unit, a NICU. But at Halifax, they say they're not really ready for a baby that young. So he refuses to accept that patient transfer, but decides that they should go to the Arnold Palmer Hospital. It's a children's hospital over in Orlando. It's a significant distance. It's an hour ride. But the sending physician feels that it's unlikely that she would deliver in less than an hour. So Dr. Milton calls the Arnold Palmer Children's Hospital. They accept the patient, and he calls the ambulance service to make the transport. So the ambulance shows up, does the transport, and 15 minutes into the ride, the water breaks, and the patient gives birth to a child. The child is named Addison, and the baby was born breech and had trouble breathing. The paramedic performs CPR, puts oxygen on the baby. They diverted to a regional medical center, which was just about 5 minutes away. And then they were sent on further to the Arnold Palmer Hospital. So the child survives, but has cerebral palsy. And the hospital was named in the lawsuit, and the doctors were too, and they were sued. And the lawsuit settled for $1.4 million. Then the ambulance corps, the ambulance company, was found negligent for accepting transport because they were not equipped to handle that kind of call. And they got nailed for $10 million. Let's take a look at some of our local protocols. In Stanford, we have a listing of the drugs or devices that can be handled at the paramedic level, at the SCT paramedic level, and when no EMS can handle it alone, they need hospital staff. You can see that typically drugs that are carried by a paramedic in the field can be monitored by a paramedic in the field. However, drugs that we don't routinely carry, for example, Dilaudid, while it is an approved medication for paramedics, we don't typically carry it, that becomes an SCT drug. So we have a large list of drugs that are available. For example, some are categorized. We can transport at the paramedic level all nitrates for angina care. We can also transport as SCT paramedics all calcium channel blockers and all beta blockers. However, it's understood that some antiarrhythmics are carried by paramedics in general. So a regular paramedic can transport a patient on magnesium or on procainamide. One category that's easy is antibiotics. Any patient who's taking antibiotics by IV is to be transported by an SCT level paramedic. We can share this list with anyone who's interested in it. One interesting one is that Stanford paramedics do not carry Phenergan. However, it is an approved state medication for paramedics, so they consider it to be SCT. One of the important documentation tools that we use is the SCT worksheet, which is approved by our medical director. And to complete this form, the paramedic should start it out. We can add a label here from the hospital, put in our internal run number, and then complete all the boxes as appropriate. The basic demographics should be listed, and we should know exactly where the patient is going and how to get a hold of the destination in case we need to change our plans. The nurse and paramedic should complete the vital signs section and information about any airway or ventilatory status, and then list all the IV access and medications that are running. If the patient has a chest tube, a Foley catheter, they should be documented here, and we should get a recent set of the patient's lab values and ABGs. So the front side should be completed by the paramedic and the nurse. On the back side, the physician can be directed to fill out the sections in red. So we need a name that's legible and a direct phone number, a cell phone or a desk phone that will be answered, and a list of the possible or probable complications in transport. Also, any drug that's being run that is outside the normal scope of a paramedic needs to be identified with a titration range and a therapeutic goal. So for example, the titration range is how many milligrams or micrograms we would adjust it by, and the therapeutic goal would be the end pulse or mental status or blood pressure. And then any additional orders that are within our scope of practice. There's 3 places for signatures. 2 of them are mandatory. The sending physician must again print his name and sign the name, and the paramedic must print the name and sign their name. If the patient is intubated, 1 additional signature is required by the receiving physician at the destination facility. Well, this completes the initial part of our SCT training. If you have any questions, feel free to get a hold of me. Thank you.